Okay, guys, it's 9:30, so we're going to go on ahead and get started. On behalf of Hannah, my co-moderator, and I, welcome to this session. Just a quick reminder, you can ask questions through the app. We're going to hold all questions and answers until all the presenters are done speaking. And then that way we just have a good portion of time. You can either put questions in the app or there is a microphone in the middle of the room. So to start, I would like to introduce Dr. Hannah Fahn. She's a clinical associate professor in the Department of Clinical Pharmacy, College of Pharmacy, and faculty affiliate for the Susan B. Meister Child Health Evaluation and Research Center at the University of Michigan. She practices as a clinical pharmacist specialist in pediatric pulmonary medicine with a focus in CF at CS Mott Children's Hospital. She previously served as faculty at the University of Arizona Colleges of Pharmacy and Medicine, as well as associate research scientist for the UA Asthma and Airway Disease Research Center. Dr. Fahn received her doctorate of pharmacy from the University of Michigan and completed a postdoctoral fellowship in pediatric pharmacotherapy at The Ohio State University. She has been recognized for her contributions to clinical practice, service, and research. She previously served as president of the Pediatric Pharmacy Association and was named Fellow of the American College of Clinical Pharmacy at the Pediatric Pharmacy Association. Her research interests include patient caregiver medication education and self-management, medication use in schools, and interprofessional care of children with chronic conditions such as CF and asthma. I'm pleased to have her here today to share with us updates on sleep disorders and CF.
Thank you so much for having us, and we're going to talk a little bit about, I guess it must be mouse. Okay. So our agenda today, we're going to go through some broad updates on sleep disorders and CF in both pediatric and adult populations, and then we're going to hear from a person with CF and their experience with sleep disorders, and then 3 amazing abstracts regarding sleep disorders and CF. And then, of course, we're going to do the Q&A at the end. So, as we know, sleep is important. We're all here this morning. Hopefully we got enough sleep. For those of us who are from different time zones, you probably get what I'm feeling in terms of the lack of sleep these days. But sleep is necessary for various reasons. As we know, it is restorative in terms of building muscle, bone, and activating the immune system, as well as for the mind in terms of consolidating learning and memories. And like other chronic conditions, including many chronic respiratory conditions, CF can lead to disturbances in sleep architecture, duration, and quality. And as we know it, as you'll see from our abstracts today, and hopefully as a takeaway message, that sleep should be evaluated on a routine basis in people with CF, and that poor sleep hygiene is common, especially in our adolescents, but it can be abroad across other age groups as well. And that decreased sleep duration and quality are often overlooked. I know we have limited time when we see our patients in CF clinic visits, but this is an aspect that we should probably be considering as part of our overall assessment. And as I mentioned before, sleep quality is important for both physical and mental health. And so when I'm talking about sleep challenges or disorders, these can include these various items here, as well as others, but to highlight decreased sleep duration, as we'll talk about due to various causes, both physical, treatment-wise, and otherwise, insomnia, restless leg syndrome, and decrease in poor sleep quality affected by various factors, and then sleep-related breathing disorders, including obstructive sleep apnea. Now, the data in people with CF has been increasing over the years, both in pediatric and adult patients. This growing data has been encouraging and helping us to best understand how to optimize sleep in our patients. In the pediatric population, we do know that it's been reported up to 40% of children may have some form of insomnia, and that they have a higher respiratory event indices compared to their counterparts who do not have CF. And there is some conflicting data out there regarding the percent of REM versus total sleep time in people with CF or children with CF, and that there is a rise in data, thankfully, on sleep disordered breathing in children with CF, and that continues to expand. In our adults with CF, we have learned from the current literature that up to 60% may have less than 90% sleep efficacy, so their sleep quality is poor, and that they have a wake after sleep onset or WASO exceeding 20 minutes. And they often have delayed sleep onset, and the frequency of restless leg syndrome is increased. In both populations, we do know from the current literature that lower nocturnal saturation naters accompany with poor sleep efficiency, as well as possible nocturnal hypercapnia due to impaired ventilation during sleep. And much of the data supports a correlation between lung function, disease severity of FEV1, and nocturnal hypoxia. So what factors are contributing to poor sleep in people with CF? So this is a very long list, and some of these may not be surprising, but the symptoms of chronic cough and bronchial secretions can interrupt and cause poor quality of sleep. Airway obstruction as a result of disease process, including chronic airway inflammation and infection, and exacerbation specifically can also decrease sleep duration and quality. Reduced lung function, as mentioned before, nasal polyps can also affect it per the literature, as mentioned, and poor sleep hygiene. Our adolescents, especially not only from an age group from adolescents, but also in general. Musculoskeletal pain has also been noted, as well as behavioral health conditions, including depression and anxiety. There are GI manifestations of CF that can affect people with CF in their sleep, including increased frequency of stooling, gastroesophageal reflux, as well as abdominal discomfort and pain that may be due to CF itself or due to medications that they take. Overnight feeds can interrupt or disrupt sleep. And then respiratory treatments, as we'll talk about in the next slide, including medication side effects. So when we're talking about medications, I'm not talking just medications that are taken, prescribed, but also supplements. And so this is not an all-inclusive list, but these are case examples that we may see in people with CF. For example, beta agonists, if we take our respiratory treatment right before bed and we're using our albuterol as part of that treatment, that albuterol may cause someone to be a little bit more awake and alert and have difficulty falling asleep. Systemic steroids, as we know, do cause insomnia, and so we try to encourage dosing in the morning versus at night. CFTR modulators such as ETI therapy or Trikafta can also disrupt sleep and cause insomnia for some patients. SSRIs or selective serotonin reuptake inhibitors can also affect sleep, as well as their counterparts in the norepinephrine reuptake inhibitors or SNRIs. Stimulants, of course, in the treatment of ADHD. There have been some literature to suggest that high doses of vitamin D, depending on what time you take it, can affect your sleep onset. Garlic supplements have also been mentioned in various parts of literature, as well as coenzyme Q12 or Q10. Antihistamines, depending on if you have a paradoxical effect, for example, taking an antihistamine and having more of a hyperactivity reaction. Antihypertensive agents can also cause it, including things like ACE inhibitors, where we have that nighttime cough or some leg cramps. Some of the cholesterol medications can also lead to leg cramps, which can affect sleep as well. Nicotine patches, if applied in the evening time, of course, that will cause some stimulation and lack of sleep. And then over-the-counter migraine medications, such as those that have caffeine in the formulation, will also affect sleep. So the consequences of poor sleep in people with CF are multiple-fold. And that can include effects on mental health and physical health combined, including depression, anxiety, attention deficits over time. It affects quality of life, including the ability to work and to perform academically. There may be some neurocognitive dysfunction. And with people that have poor sleep at baseline, that may exacerbate their pain and pain perception as well. Immune dysfunction may be a result of that as well, including some increased inflammation, metabolic dysfunction, and then in overall populations, cardiovascular disease, and may even affect all-cause mortality. So the things that we know in sleep is that we know we need it, we need to improve it, but there are also gaps in terms of how can we best help our patients. And so the current gaps and needs in CF include the role of learning more about the role of sleep duration and the quality and how that affects CF-related multi-organ morbidity. Should we have guidelines out there specific to people with CF, children and adults with CF, in terms of assessment and management? And then, of course, increasing CF team members' awareness regarding the importance of sleep and contributing factors so that we can all work together to optimize that and optimize sleep duration and quality. So as we transition now to our other speakers, I just want to have some takeaway points that, as we know, sleep is important. People with CF can experience various sleep challenges throughout their lifetime and due to various factors. And this ultimately will affect daily function and quality of life. And so CF-specific research in the realm of sleep disorders is definitely warranted and is ongoing, and I'm hopeful for more data. And so we're going to transition now to a speaker who will be able to speak from experience of having sleep disorders. Miss Laura Blumstadt has lived with CF and is a patient at University of Nebraska Medical Center since 1993. She is a special education teacher from Grand Island, Nebraska, and she's recently received her master's degree in education. And she has a sibling who has passed from CF and is a survivor. She herself is a survivor of CF, diabetes, and breast cancer. Please welcome Laura.
Thank you, Dr. Fawn. I think she just described me to a T. So my name is Laura Bloomstead. I am from Nebraska. I'm an Air Force brat, an Army wife, and a teacher. I am a CF survivor of 43 plus years. I'm a diabetes survivor of 27 plus years, and I'm a breast cancer survivor for 2 plus years. This was me about a year old. I've always loved this picture, but my mom actually just talked to me. I asked her to find it for me, and she said that she loved this picture because it was pretty much my first picture that I didn't look sick. This is me about a year old. I was probably maybe twice my birth weight at a year, but I just love how happy I was in this picture. So this is my sister, Mandy. Amanda, take your pick. She was my best friend growing up. She also had CF. We were inseparable as a kid. The only thing that separated us was the hospital sometimes. It was really nice having someone to share this disease with and all the baggage that comes with it. We celebrated milestones and trudged through the not so good times. We knew what each other were going through. The hardest part about losing her is that I no longer have that person to talk to about how I am feeling or what I am dealing with. I also, unfortunately, watched her die twice. Once from the horrible lung disease that robbed her of her breath, and the second was when she rejected her lungs. The first time, she never once told me she was dying. The second time, she came to me, she looked at me and she said, "I'm dying." I said, "I know," and we never said another word about it. And I said goodbye to her in September of 2013. It's hard to believe it's been 10 years, but I love this picture because it was actually the only picture that we actually really do look alike. My CF teams all through the years always said that we looked alike. We never did. I never thought it. I always had glasses and brown hair or brown eyes. I don't know. I'd have to consult with my CF team. So this is my family. The first picture up here in the corner was back in 2008. This is actually when we found out that my sister was pregnant with her little one. The next picture is my bro. He was very, very special to me, as he was my bro. He also just passed away this last May, but not of CF. Unfortunately, complications of this, that, and the other. The next picture is my dad, myself, and my niece, Trifina, which is Amanda's daughter. The next one is my mom and dad. Even though this picture is very old, it's still the best picture of my parents. My husband, John, and I, we have celebrated 21 years of marriage, but have been together for 29. We were high school sweethearts. He swept me off my feet my freshman year, and I've loved him ever since. And he is my rock, as Jennifer and my team can attest to this fact. My oldest sister, Tammy, with her 3 daughters, Renzi, Shea, and Yara. In the bottom left corner is Manda and her daughter, Trifina, about a year before she passed away. The next picture is of me and my dad and my sister. And then finally, my little brother, or my baby. He was only about 3 years younger than me, but he was my baby. He passed away in 2005, but not of CF. Education. So I graduated from high school in 1998. I received my undergrad in 2003, and as they said, I just received my Master's of Education in 2023. It's a really long, boring name, but basically I can teach from birth to 21 any student in special ed. I plan to continue my education because I'd really like to add doctor to my name. And of course, I started my master's during my bout with cancer. I was not doing anything else that summer except for chemo, so I was like, might as well start my master's. So, the early years. I was born in Landstuhl, West Germany. I grew up in San Antonio and Wichita Falls, Texas. I was a military brat. I was diagnosed with CF at the age of 5 months. My mom was accused of being a hypochondriac and passing Amanda's disease onto me. Although I'd only gained 1 pound since being born, I had stopped growing in general. Mom said I was coughing at birth, and after I was finally diagnosed, I was able to get the treatment. I was the sicker of the two of us, but I basically grew up in the hospital. But Amanda did not see the inside of a hospital until she was 9 years old. She had digestive issues and other stuff, but I was the sick one. I was also hospitalized every 6 to 8 weeks. And being in the hospital, there is never good sleep. Tell me someone that can sleep well in a hospital, and I'll tell you they have been given something to sedate them or getting happy medicine. I was also very underweight. I did not register on the growth chart until middle school. I was also receiving tube feeds at the time and gained weight finally. In 1992, my parents moved to Nebraska. I believe this is where my health made a huge change. I was not constantly being exposed to the pollution from Texas, and I also gained proper weight. I felt that this gave my body the ability to fight off the little things and not make me very sick. This also contributed to improved lung function and better weight. And once we moved to Nebraska, I was only hospitalized maybe once a year, which was very odd for me. After I graduated in 98, I went to college, and I was, again, hospitalized almost every finals, lovely stress. This was really hard for me to explain to my professors that I just needed to finish my finals so I could relax and get well. All but one was actually willing to work with me, and I graduated in 2003 with high honors. I married my high school sweetheart in 2002, and then as a teacher, I don't know if many of you know this, but teachers pick up everything their first couple of years of teaching, and I was no different. Dr. Murphy questioned my choice often when I would get colds and end up in the hospital. Amanda was a nurse, so I'm not sure which one was worse. I picked up every sickness that came along. My second year was so much better. During my teaching career, I have the cleanest classroom in the school. After the janitors clean, I would go back through and clean again. I never picked up the swine flu or COVID, just everything else. So one of my major activities that I've done is the bike ride across Nebraska. My dad was a long-distance bicyclist, and I love to do it as well. 450 miles in 7 days across Nebraska. Anybody tell you Nebraska's flat? I beg to differ. My first year, this was the end of my first year, this picture, and that year was a very interesting year. The next year we actually got me on oxygen therapy, and it was so much better because I was actually able to sleep at night, if you can call it sleep, with 400 to 500 people sleeping around you. But I did so much better. And my aunt, which is the one that's to the left or right, or I don't know. My aunt there is the picture. She did it with me. She's like, yeah, you're doping on oxygen. It's not fair. So now sleep. I I do have a love-hate relationship with sleep. I love it. It doesn't necessarily love me. My husband always jokes that I could sleep till the crack of noon, especially on the weekends. If allowed, this is a must, as during the week I have my job and everything else, and so the weekends is where I really get caught up on my sleep. I usually don't really get into a good sleep until about 3, 4 in the morning, and my alarm clock goes off a little bit before 6. So coughing always used to wake me up through the night. When you cough for a living, that greatly affects all activities. If I was sick, there was no sleeping. I would literally cough for 3 to 4 days straight, even with breathing treatments. Once it finally started breaking up, I could get a few hours or between breaks to sleep. My recliner was my best friend when I was sick, sometimes even when I wasn't. When I was younger, my parents got me a beanbag to help me sit sleeping up. Laying down, even when I was well, would always set off coughing fits. And I always had major sinus issues and have had 6 or 7 sinus surgeries. I kind of lose track. Stress. This isn't even a discussion. Carcolepsy. This is kind of a term I've heard about from other places, but basically anytime I was in a vehicle, I would fall asleep. Driving, not driving, whatever. So sadly, my husband would have to drive most of the time. I have finally enjoyed getting into a vehicle now and not falling asleep thanks to my CPAP therapy. So some of my sleep adaptations that I would kind of talk about. I know night feedings can cause issues with some people. I think it actually helped me sleep more because I wasn't waking up starving, one thing. I was gaining that weight that I needed desperately, but I also woke up with the tube wrapped around me many different ways and sometimes even around my neck. My diabetes, it does interrupt me during sleep because sometimes my sugar's high, sometimes it's low. And then there's some nights that I'm just like, I give up, I'm just gonna get up because my sugars and I have disagreements about who wants to sleep. I did start on oxygen. I don't exactly remember when, but it was on and off for a couple years and then continuously for about 2 or 3 years before I was diagnosed with sleep apnea. And I would go up to 4 liters a night. Not sure if anybody has slept with oxygen on, but 4 liters going in your nose at night is like a fan on full blast through up your nose. And so it's not really the greatest sleep as anyway. I did find out this spring that I still need oxygen in high elevations though. So with my CPAP therapy, I still needed oxygen at night. Now, let's see if it'll go to the next one. Okay, Trikafta. This was like my aha medicine. There's 2 periods in my life, before Trikafta and after. I knew this was something special because Dr. Murphy actually got giddy when he was talking about this medicine. There's been many new treatments along the way in my 40 years, but none have gotten my doctors this excited. So a quick story about my first day. It was a Saturday and I was getting ready to ride my bike. I was on a trainer in my basement. I was tired, I was exhausted. I really didn't want to, but I was like, I'm just gonna do it. Well, this is my first dose of my Trikafta. About 45 minutes after riding my bike, my brain was like, hey, idiot, take a deep breath. I was like, what? And I was just like, hey, take a deep breath. And I took the biggest, deepest breath I had ever taken in my entire life. And I was like, I was just like, what was that? And then it was like, hey, idiot, take another breath. And I was like, okay. And I could breathe all the way to my toes. It was the weirdest thing. And then I called my mom, and I'm like crying. I'm like, Mom, listen to this. I can breathe. And then I called my husband because he was at work, and I'm like, listen to me. And we're like all bawling and crying. And that day, I literally ran everywhere. And it just, my sister, where she was buried kind of near where I was staying or was living at the time. And I actually took that box top to her grave, and I bawled with her at her graveside and left that box there for her. And I said, Amanda, this is for us. And it was just the greatest moment. And now my husband tells me to slow down. But with this, I did have increased or less need for sleep because I had so much energy. I think that first year I only slept like 4 hours a night because I had so much energy and I could breathe, and it was crazy. The biggest factor was no coughing. I don't cough anymore. And my mom and my dad are like, it was the weirdest thing for them because they had heard me cough for almost 40 years, and not coughing is a really great thing, especially for the fact that this came out. I took my first dose 6 months or about 5 months before COVID hit, or the big part of COVID. Because as a CFer with my previous cough, I would have had to hide in a basement. So breast cancer. If I didn't have enough to deal with, my body needed a new way to slow me down. I was diagnosed with breast cancer 2 days after Christmas in 2020. What a way to end a horrible year. I went through a double mastectomy with reconstruction, 8 rounds of chemo, and put into medical menopause. This was a shock to my system, and between the chemo, massive steroid doses, and horrible hot flashes that I could tell you the time based on the hot flashes. This greatly affected my sleep. I would get cooled off and comfortable just for another hot flash to hit. I was finally able to get some medicine that helped with it a little bit, but now they're still every 45 minutes to an hour and a half. So it took about a year for my body to finally accept what I did to it. It's still not happy though. Not sure if I'll ever get back to the chemo or to what I was previous to chemo, but I'm happy, healthy, and still here. So my other factors are restless leg. If my hot flashes aren't affecting me, my legs usually are. Some nights I just have to get up to get the willies out. There are many ways of accomplishing this, but it happens. My husband laughs that he sleeps with a octopus with restless leg syndrome. Again, stress and anxiety are a no-brainer. Pain. Some nights, pain is just all over. Other nights, it's not so bad. So again, everything Dr. Fawn was talking about was wrapped up in this body. Sleep. What a wonderful thing that does not come very often. And I love to talk about me. Again, ask my CF team. So thank you, and I'm gonna pass it on to Jen Rounds.
Thanks, Laura. Up next is Dr. Vazouris. He's an assistant professor and clinical investigator in the Division of Respirology, Department of Medicine at the University of Toronto. He's also a full-status adjunct scientist at the ICES Research Institute. Dr. Vazouris is both a certified pulmonologist and sleep medicine specialist. He undertakes observational and health outcomes research. His research interests include understanding the use and potential pulmonary health effects of psychoactive and sedative medications within chronic respiratory disease populations, and evaluating the impact of sleep breathing disorder on medical comorbidity, especially chronic pulmonary diseases. Welcome, Dr. Vazouris.
Thank you. Thank you for that introduction and the opportunity to speak at the conference. I appreciate it. I have no conflicts to disclose. So there's not a lot of data on the topic of sleep breathing disorders in the adult CF population, and that's what inspired us to do this small study. The little data that's out there is old, it's decades old, and it's based on small numbers of individuals. Obstructive sleep apnea, OSA, this is the most common sleep breathing disorder, and it has, the few studies that are available show that it's of low frequency or even absent in adults with CF, and that isn't a surprising finding because CF has historically involved people who are young in age and have low weight, and being young and low weight is protective against OSA. There are other sleep breathing disorders besides OSA, central sleep apnea, hypoventilation, for example, and it's not well understood if these and to what degree they occur in CF. So there have been a number of changes in the CF field recently that can impact sleep breathing disorder. One of them is with multiple treatment advances, persons with CF are living longer and getting older, and that's a wonderful thing. But sleep breathing disorders, specifically OSA, they occur with increased frequency as one gets older. With nutritional management advances and the modulator drugs, some of which can be associated with significant weight gain, it's recognized that the frequency of overweight and obesity is increasing amongst persons with CF, and weight is an important risk factor for OSA. The CFTR modulator drugs that have kind of revolutionized care in CF and can markedly improve pulmonary health, maybe they might also help decrease the frequency and intensity of some sleep breathing disorders like sustained nocturnal hypoxemia and hypoventilation. So our purpose in this study was to take a look at sleep breathing disorders in adults with CF at our center, characterize frequency, severity, risk factors, and how they were treated. This was a retrospective study of data that had been collected. We looked at persons who had undergone a diagnostic sleep study at my center, St. Michael's Hospital in Toronto, Canada. We linked that with Canadian CF registry data. Our study looked at data over about a 20-year period. We only considered individuals, we only considered the first sleep study if an individual had had more than one, and we excluded individuals who had had a lung transplant prior to the diagnostic sleep study because new lungs may have impacted the presence and severity of sleep breathing disorder. So our study included, we had 42 individuals in total. This is just a quick description of the study sample. 2/3 were men. The vast majority were diagnosed in childhood or their teenage years. At the time of the sleep study, median age was 35 years, and the age range in our sample was 19 to 61 years old. The vast majority were Caucasian. The vast majority had class 1 to 3 mutations. The vast majority were also pancreatic insufficient. Half had CF-related diabetes. Half had nasal polyposis. Median FEV1% predicted was 62.5%. And about 60% of individuals had moderate to severe lung function decline. The median BMI was 24.2 kilograms per meter squared. That's within normal, but 45% of individuals in our study were in the overweight or obese categorization. The vast majority of individuals were growing Pseudomonas in their sputum, with Staph aureus being the second most common organism. Most individuals were growing more than one bacteria. And in terms of pharmacotherapy treatments that people were on, inhaled corticosteroids, mucolytic, azithromycin, these were the most common. Only 10% of persons were on the CFTR modulator drugs, and this is because most of our data was from the pre-June 2021 period. This is when the newest generation of CFTR modulator drugs became widely available in Canada. So this next data is kind of the meat and potatoes of the results. Epworth Sleepiness Scale was collected at the time of the diagnostic sleep study. This is a questionnaire that collects data around daytime sleepiness. The maximum score on the scale is 24. A score of 10 or more indicates significant sleepiness. The mean score of our participants was 8, so our study sample was not sleepy. Total sleep time on the test, average was just shy of 6 hours, which is great for a sleep study. The AHI, this is the number of breathing pauses per hour that an individual has during the night. And by convention, we accept less than 5 per hour as being normal. So in contrast to the limited previous literature out there, a whopping 69% of persons had an elevated total AHI. However, the majority of those had only a mild elevation in the total AHI, and mild is by convention defined as 5 to 15 breathing pauses per hour. Of those who had an elevated total AHI, the vast majority, effectively all, obstructive respiratory events, obstructive sleep apnea was responsible for that. There was really no one who had central sleep apnea. Nocturnal hypoxemia also featured prominently amongst study participants. The mean oxygen adhered during sleep was 86%. The mean time that was spent below a saturation of 90 was about 20%. About 17% of participants met our definition for having sustained nocturnal hypoxemia, and we define that as a mean oxygen saturation during sleep of less than 90 and spending at least 10% of sleep below 90. Only a minority of our study participants underwent transcutaneous PCO2 monitoring during sleep, and the reason for this is the requesting physician had to request the test, or this testing. It's not done routinely in our sleep lab. Out of the 6 individuals who underwent transcutaneous PCO2 monitoring, half had an elevated PCO2, which was defined as a PCO2 level of greater than 50 millimeters of mercury. The mean PCO2 amongst people in whom it was measured was 47, and it ranged from 37 to 54 millimeters of mercury. And this last table describes how sleep breathing disorders were being treated amongst our study participants. So out of those who had an elevated total AHI, somewhat surprisingly, about 60% were not on some form of positive airway pressure therapy or PAP treatment, which is how sleep apnea or OSA is often treated. The few people who had elevated PCO2s, most of those were on BiPAP. Sustained nocturnal hypoxemia, which could be reasonably treated with supplemental oxygen or BiPAP, 70% were not on either. This last kind of set of results now describes potential risk factors for sleep breathing disorder amongst our study participants. And these are all unadjusted odds ratios, and we considered having OSA separately and then having any form of sleep breathing disorder. So sex, age at the time of diagnosed sleep study, Epworth Sleepiness Scale score, body mass index, none of these were significantly associated with having sleep breathing disorder. Comorbidities like diabetes, nasal polyposis, these were not significantly associated with sleep breathing disorder either. Certain markers, certain CF-specific markers of poor pulmonary health, like having hospitalizations, growing Pseudomonas, polybacterial growth, none of these either were significantly associated with having sleep breathing disorder. The only factor that was significantly associated with having sleep breathing disorder was receipt of corticosteroid, either inhaled or oral. There was a 5-fold significant increased risk of having OSA or any sleep breathing disorder. Both mechanisms, potential mechanisms for this, inhaled and oral steroids, they are both known to contribute to deposition of fat around the neck area and potentially cause myopathy of the larynx muscles, and both of those would be risk factors for having sleep apnea. When we considered inhaled and oral steroids separately, no significant association was found, so I can't answer which of the two medication classes or both was contributing to the positive result in the composite variable, and the fact that we didn't demonstrate a significant positive result in either inhaled or oral corticosteroid receipt, it may speak to a power issue in our study. Interestingly, although CFT modulator drugs, I mentioned this earlier, can be associated with significant weight gain, use of this drug class was not associated with sleep breathing disorder. But if you remember, only small numbers of participants were on these drugs. It was less than 10%. Percent predicted FEV1 and Epworth Sleepiness Scale, because they're both kind of continuous variables, we examined these using linear regression in relation to sleep breathing disorder, and we found that neither was significantly associated with having either OSA or any form of sleep breathing disorder. So I presented a lot of data, and I just wanted to summarize now some of the key findings out of the data that I presented. So in contrast to the limited previous literature, we found that OSA occurred in a surprisingly large number of our study participants, 65%. Although the majority of those only had mild elevations in their total HI, and that raises some questions as to the clinical significance of the sleep breathing disorder. There was undertreatment of all forms of sleep breathing disorder. I showed earlier that 60% of people with an elevated HI were not on any form of PAP, and 70% of individuals who had sustained hypoxemia were not on supplemental oxygen or BiPAP. Male sex, being older in age, being sleepy, being overweight or obese, which are general population risk factors for having OSA, these were surprisingly, none of them were predictive of having sleep breathing disorder. And again, somewhat surprisingly, multiple CF-specific markers of poor pulmonary health, like having exacerbations, low lung function, growing pseudomonas, none of these were predictive for sleep breathing disorder. I want to acknowledge some limitations of our work. So it was based on relatively small sample size numbers, and so generalizability of our findings is an issue. Our study sample was also selected. All participants came from one center, St. Michael's Hospital in Toronto, and this was also not a random sample of adults with CF. In order to be included in our study, the person had to be referred for a diagnostic sleep study and agreed to undergo the sleep study. So again, there may be generalizability issues. While OSA and receiving CPAP in Canada necessitates undergoing a diagnostic sleep study, that's not necessarily the case for diagnosis of hypoventilation and receipt of BiPAP and supplemental oxygen. Sometimes those things occur without a sleep study or before a sleep study is done because the person is very sick. And as a result, maybe our study is underestimating the frequency of hypoventilation and receipt of BiPAP and supplemental oxygen therapies. Our goal here was just kind of describe the frequency, risk factors, treatments for sleep breathing disorder, in this study, we didn't evaluate the all-important question of does treating sleep breathing disorder result in better health outcomes, quality of life, pulmonary health outcomes. In terms of next steps, where I think things need to go is using larger study samples that are unselected. We need to confirm some of our interesting findings, and specifically the one around that OSA was quite common amongst adults with CF. Future studies should and probably will include large number of persons who are on the CFTR modulator drugs, because these can impact sleep breathing disorder through the adverse effect of significant weight gain, which is characteristic of these drugs. Future work will also need to try and elucidate, identify predictive factors for sleep breathing disorder. We were unable to really identify any predictive factors apart from corticosteroid use, and I don't know if we had done some adjusted model, if even that would have not been predictive. This is important because CF healthcare professionals need to know who to send to the sleep lab for sleep breathing disorder evaluation. Finally, the all-important question needs to be clarified of is it meaningful to treat sleep breathing disorder in adults with CF? Does it result in meaningful improvements? Are there improvements in quality of life? Are there improvements in pulmonary health markers? And given that most people in our study sample had just a mild degree of OSA, which may or may not be clinically meaningful, this point about clarifying the clinical meaningfulness of treating the sleep breathing disorder is all important. This is my last slide. This is data that does not involve persons with CF. It involves persons with COPD. It was published about 10 years ago in the Blue Journal, and in my opinion, it was kind of a seminal paper in the sleep breathing disorder field. So this was prospective data of individuals with COPD who had sleep apnea, and it looked at survival and exacerbation, comparing those who had their sleep apnea treated and those who didn't. And the group that had their sleep apnea that weren't being treated with CPAP, the red line, they had, you can see, significantly worse survival and more exacerbations than the individuals who were on CPAP and had their sleep breathing disorder treated. And these findings persisted even when the authors went on to do multivariable adjusted analyses. And this data, when it came out, a lot of people were reasonably wondering, wow, does this potentially translate, or can it be extended to other forms of chronic lung disease, and specifically obstructive lung disease like CF? And this is, I think, a very exciting and tantalizing question. Does this non-drug therapy, which just involves blowing air down the windpipe, can it impact survival, exacerbations, other important markers of pulmonary health in CF? I think that's a very exciting question. Do these findings potentially translate into the disease of CF? But we don't know the answer to that, and right now, and I think this is worthy of future research. So again, thank you for allowing me to present. Our study was funded by a grant from the University of Toronto. I want to thank Cystic Fibrosis Canada for allowing me to access their registry data, and my team that worked on this. Asma Maskoud is a medical student who worked on this project. Gia Ma was our methodologist, and Ann Stephen, Elizabeth Tullis, Andrew Nan, Claude Ryan, their pulmonology colleagues at University of Toronto who worked with me on this project, and I want to thank everyone. Thank you.
Thank you, Dr. Zzzz. Up next is Dr. John Dickinson. He's an MD, PhD, and an associate professor and physician scientist in the Pulmonary Critical Care and Sleep Medicine Division at the University of Nebraska Medical Center. He attended University of Nebraska Medical Center for medical school, then completed residency, fellowship, and postdoctoral research fellowship at Washington University in St. Louis. Dr. Dickinson cares for patients with cystic fibrosis, asthma, COPD, and non-cystic fibrosis bronchiectasis. He has studied clinical outcomes in persons with CF, including CF exacerbation and sleep quality. In his lab, he studies airway goblet cell biology, including mucin granule trafficking and the role of autophagy. Thank you, Dr. Dickinson.
Maybe I'm in the wrong symposia. No. Thank you all. Thank you for the opportunity to present our study today. Before I left, my 5-year-old was very concerned that I was coming here without him, and so he wanted to give me a friend to bring along. So this is a Lego Batman character, just to keep me company. I told him that he would be with me during the talk today. So let's see, how do I advance? Down? There we go. I have nothing to disclose. So restless leg syndrome, this is a voluntary sensory motor disorder. It's diagnosed clinically, a number of different clinical criteria based on symptoms. It's an urge to move the extremities, usually the legs. It's an uncomfortable feeling. It happens mostly at rest, and it's relieved by movement. And it mostly occurs at night or follows a circadian pattern. Prevalence is about 10% of the population, maybe a little bit higher in certain people from certain European ancestry backgrounds. Now, a number of risk factors have been identified related to restless leg syndrome, including age, female sex, and then pregnancy, iron deficiency anemia, end-stage renal disease with uremia, and diabetes. So a number of studies, I think these have been highlighted today in this session, have looked at sleep quality in people with CF. I want to highlight a few of those studies here. So this was over 20 years ago in a population of very sick persons with CF. I think in this study, the average lung function was in the 30 to 40% range. And they looked at sleep quality using the Pittsburgh Sleep Quality Index. And I'll go through this in our study in a minute, but basically this is a global questionnaire assessment of sleep quality. And in their study, they found a score of 5.7, where greater than 5 is abnormal. And they looked at a number of different factors related to poor sleep quality, including hypoxemia, hypercapnia, and lower lung function, as well as being female, being related to poor sleep quality. Here they also demonstrated there was a correlation between degree of hypercapnia and poor sleep outcomes. And I think clinically all of us have seen that in our patients who have end-stage lung disease, and hypercapnia really interferes with sleep quality. The second study looked at sleep duration and sleep latency in people with CF. And so the red triangles are showing sleep duration in a population of those with CF and normal volunteers. And the blue squares are showing sleep latency. How long does it take to fall asleep at night? And the authors were concerned about could there be a relationship with lung function, and actually they found no relationship in terms of duration and latency in terms of lung function. But what they did find was that those with CF had a longer sleep latency compared to healthy volunteers, meaning it takes longer to fall asleep in those with CF. More recently, a study out of National Jewish. This was in an older adolescent young adult population, and they were looking at a number of different sleep factors, as well as the effects of starting ETI. And in that population, they found that 36% of individuals with CF had a diagnosis of restless leg syndrome, compared to 26% in non-CF controls. And what was interesting about this study is that difference was not statistically significant, but that probably was because they had a very high number of non-CF patients with restless leg syndrome. And in their study, they looked at, through a questionnaire, a number of different sleep domains in terms of what was the effect of ETI. If it can orient you to that graph, The gray bar shows that there was no difference in sleep symptoms. The green bar indicates this symptom was better, and the blue bar means that it got worse. And overall, if you look at the different domains, meaning sleep onset latency in the first column, nighttime awaken frequency, nighttime waking duration, and then daytime sleepiness, a lot of the symptoms really unchanged post-ETI. What they did note, there was some increase in the need. Oh, I lost my Lego Batman. Oh, Andrew's going to be upset. So I thought his wings would save him. So, all right. Thank you. I have to make sure I don't kick the podium. But there was a slight decrease in the need to be on medications for sleep. But overall, I think this study illustrates that a lot of these sleep symptoms may be persistent in the post-ETI era. So we had a number of hypotheses in our study. First, we thought that people with CF would have a higher prevalence of restless leg syndrome. Second, the addition of restless leg syndrome would lead to worse sleep quality in people with CF. And our other hypothesis was that reduced lung function or having increased markers of severity of lung disease would be a risk factor for RLS prevalence and severity. So in our study, we used a number of different questionnaires. The International Restless Leg Syndrome Study Group questionnaire, which is the way we make a clinical diagnosis of restless leg syndrome. The Pittsburgh Sleep Quality Index, which I mentioned, the PSQI, is a multi-domain questionnaire study to get at sleep quality. As was previously mentioned by the speaker, the Epworth Sleepiness Scale is looking at daytime somnolence. And we looked at a number of different clinical factors relevant to CF. And our power analysis was really looking for lung function changes. And so I want to just show here, this is the example of the RLS questionnaire that was used, this is a self-administered questionnaire we gave to patients in our CF clinic. And just to briefly go through it, the questions 1, 2, 3, and then 4 is on the next slide, basically ask about a diagnosis of restless leg syndrome. If you answer yes to all 4 of these questions, then your diagnosis is RLS. And then questions 5 and 6 relate to severity. So 5 asks about frequency, and question 6 asks about severity. And so you can pretty much break it down into, if you answer yes to the first 4, then you have definitive RLS. And if you have at least 2 episodes per week of moderate severity, then you have significant RLS. So, excuse me. And so in this study, we looked, this was back in 2016, and really this is the brainchild of my fellow at the time, Dr. Bista. He was interested in RLS, and so we recruited a cohort from our adult CF clinic who had CF, and then we also looked at non-CF subjects, and these were a mix of patient families as well as people who worked in the clinic. Exclusion criteria were organ transplantation. At the time, we limited those people who had effective modulator therapy on ivacaftor, and then rheumatologic diseases. And then we were able to recruit 75 patients with CF and 75 without. And then they were administered the RLS questionnaire, and we looked at a couple different CF clinical variables. So the results from this study, we found that there was a very high rate of RLS. 1 in 3 patients in our cohort had a diagnosis of RLS, compared to 15% in the non-CF group. When we looked at significant RLS, it was 9% compared to 0% in our non-CF controls. However, we weren't able to get to some of the interesting associations we wanted to with this study, so we ended up following this to do a multi-center study, and we partnered with the University of Iowa with Dr. Pena and their adult CF clinic. And there we were able to recruit a much larger population, 90 for our center and 100 from the Iowa CF clinic. And we used a little bit different exclusion criteria. We did not exclude those on effective modulator therapy. And as you can see, this was basically bridging the time when most patients were starting on ETI when they were eligible. And we also excluded those who happened to be having a CF exacerbation. So we wanted them in their baseline state. And in this study, we administered the restless leg syndrome questionnaire, we administered the PSQI, the Epworth Sleepiness Scale, and looked at a number of clinical factors. So results here, in this study, we found, again, about 28% of those had a diagnosis of ROS, again, about 1 in 3, so similar to our first cohort, and 8% had severe symptoms. And then the non-CF cohort there on the bar graph is just referencing our first study. We did not recruit another population of controls in this study. So we looked at a lot of different clinical factors. And so in these tables, just to orient you, we have on the left of your screen the different clinical variables. And across the top, we looked at no restless leg syndrome, diagnosed ROS, and then significant ROS. And what was kind of surprising is we looked at age, BMI, sex, vitamin D levels, and then iron studies. We found no association with restless leg syndrome. But when we looked at diabetes, we began to find some interesting findings. So a presence of CFRD was significantly associated with ROS, particularly those with significant symptoms. And in the same vein, there was an association between higher levels of hemoglobin A1C and those with ROS and severe ROS. And this is shown here in this graph where we measured hemoglobin A1C in the different groups. We found a significant difference between those with significant ROS compared to no ROS. Again, looking at other clinical factors, we're really interested in lung function, and we did see an association with those with lower lung function here, and the significant ROS group compared to those with no ROS. We did not see an association at all with our CFTR mutation class, the presence of chronic Pseudomonas infection, or the presence of MRSA as a chronic infection of the airway. We did see, however, what has been described in other populations in association with SSRI use. So those with SSRI or SNRI use for anxiety or depression that tend to be more associated with ROS and significant ROS symptoms. Then we looked at some markers of disease severity, and again, we found an association. Those who were sicker, meaning 1 or more admissions to the hospital in the last 12 months prior to enrollment in the study, and more antibiotic use. So we measured the number of days people were on oral or IV antibiotics for exacerbations and found an association with ROS. So turning the page, we wanted to look at sleep quality. And again, this was using the Pittsburgh Sleep Quality Index, where a score of 5 or more indicates poor sleepers. And what was pretty remarkable, especially for Dr. Bista, who's again our sleep specialist in our study, was that a lot of our patients have really poor sleep quality regardless of ROS status. So the mean PSQI score is 8.67 across all of our CF patients. And then we looked at the Epworth Sleepiness Scale, and as was alluded earlier, a greater than 10 tends to indicate clinically significant daytime sleepiness, and our overall level was 8.7. So again, not significant daytime somnolence in our group overall. But then we wanted to look at comparisons with restless leg syndrome, and we found a lot of interesting findings. So in terms of the Epworth Sleepiness Scale, those with severe ROS were associated with higher daytime somnolence, and that over 10 there for that Epworth Sleepiness Score indicates that subset had daytime somnolence. Then we looked at the different domains of the Pittsburgh Sleep Quality Index score, and I won't go into all of them, but across all of the different domains, or I think majority of the domains, we found a significant association with ROS, particularly those with significant ROS. And that's showed here in this graph, where those with significant ROS symptoms had a higher PSQI score compared to those without ROS symptoms. Then we looked at independent predictors of ROS, and we found that the higher the PSQI score, meaning the poor sleep quality, predicted for significant ROS symptoms. And in the same vein, hemoglobin A1C also predicted for significant ROS symptoms. So conclusions in our study. We found that restless leg syndrome is very prevalent in adult CF populations. Factors associated with restless leg syndrome include low lung function, frequent exacerbations, CF-related diabetes, especially those with elevated hemoglobin A1C, and the use of SSRIs and SNRI medications. We found lower sleep quality across our populations, but especially those who have severe restless leg syndrome. It seemed to affect sleep quality the most. And finally, hemoglobin A1C and the higher PSQI score were independent predictors of RLS severity. So some of the limitations of this study, I think most of the, as you probably could see from this data, most of the findings were really driven by those with significant RLS symptoms, and that was a smaller subset of our population overall. We really are interested in looking at lung function as a driver of this. We were hoping to recruit 260 patients. There was a few things going on in 21, so we had trouble getting other centers to coordinate with us, so we were a little bit underpowered. We got 200 patients. So unfortunately, we did see some associations, but they were not. Lung function was not an independent predictor of CF in our group, and I think it's probably because we were underpowered. This is a questionnaire-based study, and we didn't use any polysomnography. There are some mimics of RLS that can be diagnosed in the sleep lab, and we didn't look for those. So just to acknowledge, this really is the work of Dr. Bista, who is the fellow and now faculty at the University of Nebraska Medical Center, and he has been the driving force and energy behind this study. I want to acknowledge Dr. Pena from the University of Iowa for his collaboration in this project, Dr. Murphy at the Adult CF program, and my colleagues at the University of Nebraska. And just to acknowledge that this paper, I just found out this week, was just accepted in the Journal of Cystic Fibrosis. So this data set will be available hopefully in the next couple of weeks for review.
Thank you, Dr. Dickinson and Batman. So up next, we have Rachel Heritage. Rachel is a registered respiratory therapist from University Hospital's Rainbow Babies and Children's in Cleveland, Ohio. She's a dedicated member of the Cystic Fibrosis Multidisciplinary Care Team. Rachel has worked as a respiratory therapist for 11 plus years. She started in CF in 2015. She has a background in sleep, pulmonary function testing, and research. She completed the CF Foundation's Respiratory Therapist Mentoring Program in 2016 and received the Kristen McFall Memorial Respiratory Therapist Stipend in 2017. She holds an Associate of Applied Science Respiratory Care from, oh boy, I don't think I can say that, Cuyahoga Community College. Thank you, Rachel.
Thank you. Hello, my name is Rachel Heritage. I am from University Hospital's Rainbow Babies and Children's in Cleveland, and I am very happy to present to you data from our center gathered from a retrospective review of nocturnal pulse oximetry studies that were completed pre and post initiation of elezicaftor, tezacaftor, ivacaftor. There was no relationships to disclose related to this presentation. So the learning objectives are define the process of a nocturnal pulse oximetry in POC study and recognize the qualifications for obtaining nocturnal oxygen in the home, gain knowledge regarding the effects of elezicaftor, tezacaftor, ivacaftor, ETI on nocturnal oxygen requirements, understand the importance of MPOC studies, especially in the era of highly effective modulator therapy. Since the initiation of highly effective modulator therapy with ETI, people with cystic fibrosis have experienced an increase in forced expiratory volume at 1 second, also known as the FEV1, and a decrease in pulmonary exacerbations. An important additional benefit to consider is a potential discontinuation of nocturnal supplemental oxygen, which could significantly impact the quality of life for people living with CF. So what prompted us to consider looking deeper into nocturnal pulse oximetry studies for people with CF that required nocturnal supplemental oxygen prior to the initiation of ETI? I have on the screen information about subject number 3 from our chart review. He, who was a 20-year-old male with an FEV1 of 35% of predicted prior to ETI. Due to his advanced lung disease, it was time to screen for adequate oxygenation while asleep. An impact study was completed in June of that year. The study confirmed that he required oxygen with sleep. However, the physician questioned the accuracy of the test due to the significant amount of time the subject's pulse ox was at or below 88%. A repeat impact study was done in July and again confirmed the need for supplemental nocturnal oxygen. Nocturnal oxygen was ordered for the home. In August, a sleep study was completed, which ruled out obstructive sleep apnea and again confirmed the need for oxygen while asleep. At his follow-up clinic visit, ETI was initiated in late November. At his follow-up clinic visit in February, the subject informed to his physician that he had stopped wearing his nocturnal oxygen because he was feeling so much better since starting ETI. So in March, a repeat impact study was performed off oxygen, and the results showed 0 minutes at or below an SpO2 of 88%. So nocturnal oxygen was discontinued. Before continuing into our retrospective chart review, let's take a closer look at impact study process. So what is a nocturnal pulse oximetry study? This is a test that evaluates your oxygen needs while you're asleep. A pulse oximeter can measure blood oxygen saturation levels through a small clip that is usually placed on your finger. An oximeter reading only indicates what % of your blood is saturated with oxygen, known as the SpO2 level, as well as your heart rate. While you're sleeping, the oximeter records data continuously throughout the night, and then the results are compiled into a comprehensive report for your physician to review. Here are 2 examples of impacts reports. Reports may differ depending on the company or program used for testing. Reports include breakdown of saturation levels and heart rates throughout testing duration. We are looking for the total time at or below an SpO2 of 88% to see if a patient qualifies for nocturnal oxygen. Impact studies can be completed in the home or in the hospital. Testing must be performed while the patient is in a chronic stable state. So if testing is done during a hospital admission, it must be done within 48 hours of discharge. To obtain oxygen equipment in the home, most insurance companies follow Medicare guidelines. This information can be found on cms.gov, Centers for Medicare and Medicaid Services, under Manual Section 240.2, entitled Home Use of Oxygen. The guidelines have recently changed as of January 3rd of this year. Our retrospective chart review was done based on prior guidelines, which were a minimum of 2 hours of recording and at least a total of 5 minutes at or below an SpO2 of 88%. To date, this is the number of people with CF at our center who have completed an impact study and who have completed a sleep study, home or in the lab. Out of roughly 190 adults, we have completed 36 impact studies, 25 people qualified for nocturnal oxygen for home, and 17 of those people are using nocturnal oxygen. 32 sleep studies have been completed, 19 confirming obstructive sleep apnea, severity from very mild to severe. 5 people are using home CPAP machines, 3 people attempted CPAP but were unable to tolerate it. If you notice on the previous slide, out of the 25 people who qualified for nocturnal oxygen, only 17 agreed to wear it, leaving 8 people who declined initiation of nocturnal oxygen therapy. Here's a list of some common reasons we have heard from our patients who do not want to wear oxygen. Many misconceptions, like the fear of becoming addicted to oxygen, feeling the requirement of oxygen is the beginning of the end, denial of advancing lung disease, the stigma associated with wearing oxygen, feeling embarrassed or ashamed, and the equipment can be expensive, noisy, uncomfortable, and inconvenient. So now that we know a little more about nocturnal pulse oximetry studies and the number of people at our center that require nocturnal oxygen, let's get back into the review. After initiation of ETI, our team started to see more patients discontinuing nocturnal oxygen, which prompted us to take the closer look. Our first step was to determine how many people had qualified for nocturnal oxygen prior to initiation of ETI. Out of those people, how many had both a pre and post ETI impact study? After a review, we identified 12. The data points we collected that we thought would be useful in our review included the following: sex, age, the FEV1 percent most closely associated with the impact study date, pre and post ETI, the total number of minutes with an oxygen saturation at or less than 88% for both pre and post ETI impact studies. And lastly, the average of 3 resting pulse oximetry measurements obtained in clinic prior to and after initiation of ETI. So here are 12 subjects that had pre and post testing. Every subject had a decrease in time at or below 88% post ETI. Subjects' ages ranged from early 20s to early 50s, included 4 females, 8 males. The FEV1 percent predicted ranged from 29 to 89%. 6 of the 12 subjects also completed sleep studies. 3 were negative for OSA, and 3 had positive sleep studies. As expected, the FEV1 increased for 11 of the 12 subjects. After initiation of ETI, subject number 9 had no change. The average of the 12 subjects' FEV1 prior to ETI was 42, and after initiation of ETI, the average FEV1 was 48.9%. We found this is to be pretty striking data with the total of the combined minutes of our 12 subjects, SpO2 below 88%, to be 830 minutes, but after initiation of ETI, the total combined minutes was only 38 minutes. Out of our 12 subjects, 9 no longer met the requirements for nocturnal oxygen therapy after initiation of ETI. Although all had significant improvement in their oxygenation while asleep, 3 people did not reach the threshold to stop using nocturnal oxygen. Of note, 6 of the 9 people who qualified to discontinue nocturnal oxygen were also categorized as having advanced lung disease, which is a FEV1 less than 40%. So let's take a closer look at the 3 subjects that did not reach a threshold to stop using nocturnal oxygen. Subject 10 almost met the threshold to discontinue. Post-ETI, her impact study results showed 5.3 minutes at or below an SpO2 of 88%. She did have an in-lab sleep study performed post-ETI, which did rule out OSA. Subject 11 had advanced lung disease and had a huge improvement in time spent at or below an SpO2 of 88 during sleep. Prior to ETI, 276 minutes, post-ETI, only 12. Subject 12 did not have much of a change in his FEV1 post-ETI, but minutes at or below an SpO2 of 88 during sleep did improve from 32.9 minutes to 11.4. Something to note, several years prior to ETI, the subject was diagnosed with moderate obstructive sleep apnea and obtained CPAP equipment in the home. A follow-up impact study was done on CPAP without an oxygen bleed-in. Results showed that the CPAP did resolve his hypoxemia. Unfortunately, the subject was unable to tolerate CPAP, so he remains on nocturnal supplemental oxygen. Subject 3, which I discussed earlier in the presentation, had the most significant decrease in minutes post-ETI, 351 minutes to 0 time, at or below 88%. Subject 4, who was in her 20s, had the biggest change in FEV1 post-ETI. Her FEV1 went from 35 to 52%, and OSA was ruled out prior to initiation of ETI. Lastly, let's talk about subject number 6, who is a 43-year-old male with an FEV1 of 89%. His story starts out after a hospital admission, which he did require supplemental oxygen. At his follow-up appointment, his physician discussed obtaining an impact study or a sleep study due to his recent hypoxia. The subject was agreeable to an impact study. An impact study was done in July, which showed 6.8 minutes at or below an SpO2 of 88%, qualifying him for nocturnal oxygen. Due to his high FEV1, his physician recommended a sleep study to rule out obstructive sleep apnea. In September, a in-lab sleep study was done. Results confirmed a mild obstructive sleep apnea. The study also confirmed the need for oxygen. The time spent less than an SpO2 of 88 was 55.5 minutes. At that time, the subject did decline trying an auto CPAP, and he declined nocturnal oxygen. But he did say he would consider trying ETI. During a hospital admission in March, ETI was initiated. An impact study was completed shortly after starting ETI while still in the hospital. The results showed only 4 seconds below an SpO2 of 88% in 1 minute, and 1 minute and 52 seconds below 90%. ETI significantly improved his oxygenation while asleep in a short amount of time. Several months later, the subject stopped ETI due to side effect and lack of improvement. After discontinuation of ETI and our knowledge of his previous testing off ETI, his physician recommended reconsideration of nocturnal oxygen and CPAP. After some thought, the subject did agree to try auto CPAP. In conclusion, a repeat impact study was done on his auto CPAP, which almost completely corrected his nocturnal hypoxemia. Results showed only 1.1 minute at or below an SpO2 of 88%. We also looked into resting pulse oximetry measurements to see if it would be a predictor of nocturnal desaturation. After our calculations, there was no significant difference between the average of 3 resting pulse oximetry measurements attained in clinic prior to and after initiation of ETI. Discontinuation of nocturnal oxygen can greatly improve the quality of life for people living with CF. Oxygen can often cause nasal dryness, skin irritation. Oxygen can be costly and inconvenient, particularly with travel, and is often a source of psychological stress for those who wear it. In conclusion, we observed an improvement in oxygenation, allowing a significant proportion of people with CF at our center to discontinue nocturnal oxygen therapy, including those with advanced lung disease prior to initiation of ETI. Due to the significant improvement in nocturnal oxygen saturation noted in our CF population, we highly encourage others to reevaluate the need for nocturnal oxygen therapy post-ETI initiation. Thank you for the opportunity to present our data from our review. Please come see us at poster 723.
Thank you to all of our speakers. If anybody has any questions, you can feel free to step forward to the microphone. Otherwise, we have a few questions that have come in. I know there were a couple of questions, Dr. Bazoris, about CPAP versus BiPAP, and maybe advantages, disadvantages to both of those.
Just in general and succinctly, CPAP is the PAP therapy that's classically used to treat obstructive sleep apnea. It involves giving one air pressure to help keep the upper airway open, keep it splinted open, and that alleviates the problem in obstructive sleep apnea, which is repetitive narrowing or closure of the upper airway. BiPAP is classically used to treat more complex sleep breathing disorders, such as, classically, hypoventilation. There are 2 pressures given, one on inspiration, one on expiration, and that pressure difference allows for the expellation of carbon dioxide. So it really depends, I think, what the underlying sleep breathing disorder is that drives which of those 2 PAP therapies are used. CPAP classically for OSA, BiPAP classically for more complex sleep breathing disorders, specifically hypoventilation.
Thank you.
Rose Franco, Medical College of Wisconsin. For the gentleman from Toronto, a couple questions about your study. What do you use for a definition of hypopnea?
So we used, our lab uses the American Academy of Sleep Medicine criteria for all types of respiratory events, including hypopneas.
Which is?
There has to be at least a 30% decline in airflow with at least a 3% decline in oxygen saturation or associated with an arousal.
Actually, the American Academy of Sleep Medicine's requirement is 4% that's what Medicare covers in the U.S. You're saying you're using a 3%?
No,
rule.
so then we use 4% as
Okay.
well. Sorry, I misspoke. We definitely follow ASM criteria, yeah.
Okay. And the other piece to that would be, did you consider the sinus disease could be contributing to people opening their mouth, and perhaps that if the majority of the events that were scored were hypopneas, that they were due to maybe subtle nasal congestion that isn't really overt enough to make it onto the registry, with polypectomy or sinus surgery?
That's an interesting thought. We were a bit surprised by how much nasal polyposis there was in our sample. And again, these aren't children, they're adults with CF. And it was 50% or a bit more than that had nasal polyposis. That struck us as a bit unusual. And, it speaks to our selected sample. What you raise is a possibility, although it's known that sinonasal disease is not a large or meaningful contributor to obstructive sleep apnea. It's lower down the upper airway. That anatomy is what influences OSA. So I don't exclude the possibility, but I can't. I don't think that it would be a large contributor to our finding of OSA, in my opinion.
It may be worth investigating, because if your partial throat closures are the main thing that you're scoring, and the majority are mild, it may be that are asymptomatic because your AHI, your Epworth Sleepiness Scale scores weren't that high. It may all be getting better with Trikafta, if you will, ETI, because of improvement in sinus disease that comes with sinus congestion that comes with treatment. Just thoughts. Thank you.
Thank you. And let me just I'll just make two comments. We don't know in our sample how symptomatic or not they were. The Epworth Sleepiness Scale is just measuring daytime sleepiness, which is just one symptom. OSA can be associated with a range of symptoms. The more common was actually fatigue, not sleepiness, and we didn't have data around that, so I really can't comment how comprehensively symptomatic or not our study sample was. Studies, and this is just in the general population, where sinonasal disease was treated either surgically or with inhaled intranasal corticosteroids, that is known to marginally improve OSA. And I guess that was something that was in my mind when I was giving the first answer, that, I think it's fair to say it's generally thought that sinonasal disease does not to a large degree impact OSA, but it is a worthy thought and worthy of further study.
Hello, I'm a parent, and Dr. Fan talked at the beginning about the use of ETI or, just doing the regular treatments before bedtime, and I'm now wondering if I've been very invalidating to my child, who tells me they have a hard time falling asleep. So, Dr. Fan, what would you say is the recommended time frame that they should be taking their nighttime dose of Trikafta, or even taking their albuterol? Like, how long before they are going to bed?
That's a really good question.
That's a great question. So for some of the patients that I've had where they've had some insomnia closer to bedtime and they're doing their treatments right before bedtime, I usually will say, like, if you can bump it about 90 minutes before you go to bed, that'll give 90 minutes to about 2 hours. That'll give time for that albuterol to kind of wear off and all that sort of good stuff, as well as like just the excitement of the action of airway clearance can also keep kids up. And then as far as Trikafta, I've had some patients move their doses up about a couple hours from their normal. Some of them will do it like 9 and 9 or 8 and 8 for that 12-hour window. But I give them a little bit of a fudge factor of like about a couple hours if they need to see if that improves their sleep. I've also done swap dosing in terms of the flip dosing for Trikafta to help with insomnia.
Excellent, thank you.
Okay, we have a question, I believe, for Dr. Dickinson. They're both kind of related questions. Given what we know about the incidence of ADHD in the CF population and the higher incidence of RLS and ADHD in general, do you believe that this is a related driver mechanism? Do you think that these are independent mechanisms that are occurring?
I'm sorry, can I see this question? I was trying to get my microphone to work.
You have to wait till Ramsey's off.
Is it working now? I don't know about the association of ADHD and ROS. We didn't ask that. I would think they're probably independent of each other. The stimulants, medication certainly cause insomnia that we use for ADHD. We think the central mechanism for RLS is twofold. One is iron deficiency, so it's a little bit surprising we didn't see a difference in our population. Though it may be more central, meaning in the CNS iron deficiency, localized iron deficiency in some of the nerves responsible for motor movement. And then there's a dopamine response. So I think there's probably independent mechanisms for those two from occurring. And for treatment, the guidelines for treatment of ROS basically, first of all, looking for easily fixable causes like iron deficiency. That would be the first step. And then there's some dopamine agonists or gabapentin would be another option to be used for those who have ROS.
Thanks, Dr. Dickinson. There was a question for Laura. Laura, do you have any suggestions on how to encourage patients to try oxygen when they've denied it without even trying it?
For me, I understand the stigma behind it. It is always a psychological whatever when there's one more thing that you have to get ready for bed. One more thing. And I, as a person who has lifted those oxygen concentrators multiple times, especially my week of brand, that was fun. It's one of those things, just try it. If you don't like it, you don't have to keep using it. I'm always open to trying to find anything that helps me sleep anyway, but I know that just in general, anything this, that, or the other, I actually was more adamant about not having the CPAP because I don't like anything touching me, like my face when I'm sleeping. But after the first night of my CPAP, I was like, I felt great. So it's always a psychological battle. Anything new, anything more, anything that we have to, just for the fact that, getting up in the morning and getting to work takes so much more when you have CF than just in general. And so just adding that one more thing that you have to pack in your car, one more thing that you have to pack in your house, one more thing that you have to fight insurance about, it is a battle. And it's one of those things, why not try it, see if it helps. If it doesn't, you can say you've tried it.
Thank you.
Okay, this question is for Rachel Heritage. Does your clinic have a protocol to guide at what point you order the nocturnal pulse oximetry testing?
I guess we don't have like a protocol, but we do look at FEV1s, like people in low 40s and under. And then we do ask, we have a couple questionnaires, like we do the Pittsburgh questionnaire, and there's another one that we just started using. But yeah, we screen a lot about, sleep studies and nocturnal pulse ox studies. So yeah, we're definitely more aware of it than we've ever been. So we do a lot of them, just to roll them out.
And this question,
This question goes for anyone on the panel if they're willing. Any thoughts or pearls on what to do with a patient with insomnia and sleep disordered breathing and RLS has been ruled out?
I'll try and answer that as a sleep physician. I think my answer would be to kind of make a diagnosis as to what is the disorder going on. I'm a bit surprised to hear of a case where insomnia has also been ruled out. I mean, I think I would need to hear a history to understand what the person was experiencing to make a diagnosis and then take things from there.
And question for both physicians on the panel, what are your thoughts on home sleep apnea testing as a screening tool for adults with CF?
So the sleep physician will answer that one too. That's a very good question. Portable or home sleep testing has really taken off, especially in the United States. And it was really the insurance companies that made it take off as a way of reducing costs, because in-lab testing is more expensive. In Canada, which in the province that I'm from, Ontario, which has a public healthcare system, only in-lab polysomnography is funded, and that's why we effectively do no portable or home sleep testing. But that was a preamble to answering the question. So there are concerns around home testing in individuals that have certain chronic diseases, such as chronic lung disease of any kind, including something like cystic fibrosis. And the concern is that although home portable sleep testing has been validated and it does agree very well with in-lab polysomnography, individuals with chronic diseases, and specifically chronic lung diseases, were always not included in those studies. And these individuals, they're just sicker, they're more complex. So it's not actually known if home testing picks up as well or as comprehensively sleep breathing disorders. And my approach is when I have an individual with chronic lung disease, not only do I bring them in for a diagnostic study, but before prescribing them their PAP therapy, I evaluate that in the lab as well. I don't just rely on home testing, just because we don't know if home testing results, if they are so good in that population as opposed to the general population. So I think there's a legitimate concern around home testing in populations like CF.
Okay, this one is for,
Laura wants to add something.
So as a patient on that side, I know that going into someplace, and you saw my one picture of everything they have to attach. And mine also is I have the allergy to tape. So when they put all that tape on me, they put one on my neck, and I like literally scratched off the one of the sensors just because I was reacting so bad to it. But I know that I wasn't comfortable because the environment wasn't comfortable for me. So if I would have options of being able to do it at home versus in a lab, I would prefer the home just because I have my bed, I have my stuff that I'm comfortable with. So, I mean, I didn't even know that they could do it at home, so I'm excited.
And there's no question, home is more comfortable. That I agree with.
All right, this one is for Dr. Dickinson. Please describe the difference between RLS and PLMD, including treatment.
I can't speak to the latter treatment part of it. I might defer to you on that. But I think that the PMLS is at nighttime. During the night, that disrupts your deep sleep quality, whereas restless leg syndrome, again, is a voluntary movement prior to sleep. So, treatment differences?
So I think although restless legs and periodic limb movement disorder, they are distinct diagnoses. In all effect, the treatments are the same. My approach to managing someone with PLMD would be the same as an RLS, although they are two different, distinct diagnoses, as you mentioned.
There was also a question here regarding the high prevalence of mild AHI, and is treatment required for that? And will it make a difference for these patients?
Yeah, I think that's a very interesting question that I don't have the answer to, and I don't know that the healthcare community has an answer to. Does treating sleep breathing disorder, specifically OSA, does it result in meaningful improvements for persons with CF in either quality of life and or pulmonary health outcomes? And that question, I think, is even more relevant when you're looking at mild OSA. Having said what I just said, it is known in the general population that the total HI poorly correlates with symptoms. Even individuals with mild elevations in total HI, they can have a large number and intense symptoms, and there can be meaningful quality of life improvements, benefits treating that mild OSA. I've definitely seen that in clinical practice many, many times.
All right. Another one, Dr. Dickinson, your description of RLS as voluntary and urge related. I wonder if one aspect of treatment might follow that of OCD, such as response prevention?
So I don't know if that would necessarily mean that it's compulsive behavior. I think that, again, we think that this is a dopamine related response in the brain for motor neurons. I don't think that sort of OCD sort of treatment would overlap with that.
One question that came to my mind listening to everyone talk is, do we need to be doing more sleep disordered screening in all of our patients? For hypoxia, OSA, restless leg, does that need to be done annually? Thoughts from anybody?
As a CF patient, yes.
And just to put a shout out to your talk earlier, we have a QI project for those of you who are looking at our pregnancy population, and we are screening for exertional and nocturnal hypoxia throughout pregnancy in our patients, because there's a little bit different oxygen level that our high-risk OBs are interested in to maintain and to protect fetal health and development. And so that's something in our center we're very interested in. And I certainly agree that in our CF, our patients, it's very important to screen for this, particularly when things pop up like poor sleep quality, daytime sleepiness, energy levels. We're very attentive to that.
Yeah, I think the results of some of our studies speak to the need to evaluate this more. Our study, we found high numbers of OSA. We were surprised at how frequent it was. Dr. Dickinson's study as well, relatively high numbers of people with RLS. So I think some of the study results speak to that. And with regard to Dr. Dickinson's study, like CF is not one of those conditions that has been traditionally associated with RLS. RLS is traditionally associated with iron deficiency, chronic renal failure, diabetes, connective tissue diseases. lower extremity joint disease or intervention. Like I hadn't really associated RLS with CF, and it's kind of my colleagues' study results are a bit of a wake-up call to, oh, like maybe we should be thinking and asking about this more and evaluating for it more.
So, due to my SPED background, my special education background, I know that I deal with a lot of students with sensory issues and things like that. And I know I've worked with like that deep pressure sensory input, things like that. And I know that's sometimes what I have to do for my restless leg. Has any kind of study been done on that with, sensory input every day to help reconnect those neurons to work properly?
Thanks for that question. I wanted to make this comment at some point. I'm glad I have the chance to do it now. One of my first line management strategies for RLS is actually non-pharmacologic management, because I've seen it work in some patients. It doesn't work for everyone. And if you can avoid using psychoactive drugs chronically, everyone's in favor of that. I don't know if there is a lot of supportive evidence for the non-drug strategies, but spending time massaging the lower legs before getting into bed, and or allowing warm water to fall on the lower legs, both of these things, massage and warm water, they can stimulate blood flow in the lower leg muscles, and that is thought to potentially be helpful for RLS or involuntary leg movements. So that's typically, unless someone has really bad symptomatology, I try and get them to do a period of non-drug therapy first. And another reason why it's worthwhile doing is it is known that RLS can also wax and wane over time. There are periods of time where, for whatever reason, it's more bothersome, but then it can settle down. So it's generally, unless you have a very bad case up front, it's worthwhile giving, I think, a period of time of non-drug management before introducing kind of the psychoactive medication classes.
All right, we have another one here. In any of the studies, did you look at sleep efficiency and arousal indices, as most studies point to poor sleep quality versus significant OSA?
Yes, so in our sleep study, we definitely recorded data on sleep efficiency and arousal indices. I didn't present that data. I know the sleep efficiency number was very good, if not excellent, in our study sample. I just can't recall the arousal index data, and I don't want to just speak off the cuff and say something that's wrong. But our sleep efficiency was excellent, and as I showed, the average person in our sample slept for close to 6 hours in the lab, which is excellent for sleep lab conditions.
Dr. Vazouris, in your study, was risk stratification performed to assess SDV in patients with different severity of lung disease, especially FEV1?
That's an interesting, worthwhile question. Because we only had a little over 40 individuals in our study, we didn't feel it was worthwhile kind of doing any type of subgroup analysis. The one that's asked about is an interesting one, but we didn't really feel we had the numbers to do an analysis that we would have confidence around the results.
And last question here. What are the barriers to OSA diagnostics in CF? There are clear overlaps in the presentation of breathing difficulties and mucus thickness in people with CF and COPD at night. Should sleep medicine consults be part of routine care in this population?
So I'll let Dr. Dickinson answer as well. I'm not going to give the most comprehensive answer, but two things that I think are factors are, I don't think sleep breathing disorders have largely been on the minds of healthcare practitioners because there hasn't been a lot of data out there to help bring it to the forefront of their minds. As I said, the few studies that are out there showed that OSA in adults was low frequency if or absent. So, and I think another factor is, CF, there's a lot going on. It's a multi-system disease. There are a lot of moving parts, and it's hard to always think about everything when there are a lot of moving parts and a lot of aspects around their health that need management. And I think sometimes sleep issues, sleep quality issues get overlooked because of that. And I don't know if my colleague has more thoughts to.
Just to the question about, regular referral, I think that most CF centers are very capable at addressing and differentiating a lot of the different symptoms, and then potentially treating a lot of those, particularly nighttime hypoxia. I think the algorithm we would use is if we identify nighttime hypoxia that does not get better with corrective oxygen, or they're suggestive of rhythmic disruptions and desaturations, then we would refer to sleep medicine. Or if there's significant ROS that, for example, doesn't improve with iron supplementation or gabapentin, we would refer to sleep medicine. So, but I do think that most CF centers are capable of addressing this issue for their patients, since hopefully we'll become more aware of sleep quality issues.
Okay, thank you for all the questions, everyone. This concludes our session. Please join me in thanking all of our speakers today.